Why the concern? Why beta blocker use in COPD is controversial. It notes that COPD and cardiovascular disease frequently coexist, primarily due to shared risk factors like smoking. Beta blockers are proven to save lives in heart failure, post-heart attack, and hypertension. However, many clinicians hesitate to prescribe them to COPD patients because of three specific fears: a drop in lung function, FEV, worsening of respiratory symptoms, and triggering acute exacerbations, ECOPD. The study aims to answer, do the benefits outweigh the risks? This fear persists despite growing evidence to the contrary. There are two main goals of the systematic review. First, to evaluate the class effect of beta blockers as a group on 5 critical outcomes in COPD: exacerbations, mortality, hospitalizations, quality of life, and lung function. Second, to compare individual beta blockers against each other to determine whether any specific agent is particularly safer or more harmful for lung function. It should be noted that understanding within-class differences is novel to this review and clinically relevant because not all beta blockers are the same. This paper summarizes how the evidence was gathered and analyzed. The search covered major databases from inception to January 2021. A total of 23 observational studies and 14 randomized controlled trials were included. 3 analytical approaches were used: a traditional meta-analysis for exacerbation data, mostly observational, a network meta-analysis for FEV data, allowing indirect comparisons among 7 beta blockers versus placebo, and a narrative synthesis for mortality, hospitalizations, and quality of life because those outcomes had too much variability or too few studies to pool statistically. It highlights that the network meta-analysis is a sophisticated method that provides probabilistic rankings of treatments. Key finding number 1, ECOPD exacerbations. This paper presents the first major finding. Beta blockers are associated with a 23% relative reduction in the risk of acute COPD exacerbations, based on pooled observational data from 5 studies involving over 27,000 patients, HR 0.77, 95% CI 0.70 to 0.85. However, the caveat is only one randomized controlled trial, the Block COPD trial with metoprolol, was available, and it found no benefit in time to first exacerbation and actually signaled a higher risk of severe exacerbations requiring hospitalization. The takeaway is that observational evidence suggests benefit, but high-quality RCTs are still needed. The forest plot shows the impact of beta blocker therapy on ECOPD in patients with COPD. Beta blockers reduce exacerbation risk. Key finding number 2, FEV, lung function, network meta-analysis. This paper addresses the core safety concern, effects on lung function. Data from 12 RCTs, 199 patients, comparing 7 beta blockers to placebo showed that most beta blockers, including atenolol, bisoprolol, carvedilol, celiprolol, labetalol, and metoprolol, caused no significant reduction in FEV. Propranolol was the sole exception, associated with a mean decrease of 0.14 liters. 95% credible interval minus 0.28 to minus 0.016, which exceeds the 0.1 liter threshold considered clinically meaningful. The authors strongly emphasized, avoid propranolol in COPD. Other beta blockers appear safe for lung function. Ranking of beta blockers for FEV. This authors used a ranking table to show which beta blockers are least likely to harm FEV, based on the surface under the cumulative ranking curve, SUCRA, analysis. Celiprolol ranked highest, most lung protective, followed by labetalol, then the commonly used agents, metoprolol, bisoprolol, atenolol, with neutral effects, and finally propranolol as the worst. It is deserved to mention the authors clarify that best here means preserving FEV, not necessarily the best for cardiac outcomes. Importantly, no single agent emerged as the definitive best for all patients. The choice should be guided by the patient's specific cardiovascular indication, e.g., bisoprolol for heart failure, atenolol for hypertension. Key finding number 3, mortality and hospitalizations. This review covers 2 outcomes. For mortality, 21 observational studies, over 422,000 patients, generally showed reduced death risk with beta blockers. 17 of 21 studies favored beta blockers. However, the heterogeneity was extremely high. I superscript 2 equals 99.3%, meaning the studies were too different to combine into a single summary estimate. Many studies had confounding issues, e.g., not adjusting for COPD severity. Therefore, the quality of evidence is rated low. For all-cause hospitalization, only 3 observational studies were available, and none found a significant difference between beta blocker users and non-users. Caution should be taken that while the trend is positive, it cannot be certain of a mortality benefit from the current data. Key finding number 4, quality of life. This review highlights a major gap in the literature. Quality of life outcomes, such as the St. George's Respiratory Questionnaire, SGRQ, 6-minute walk test, 6MWT, 12-minute walk test, and SF-36 survey, were reported in very few studies. No consistent quantitative analysis was possible. The few available studies, 2 RCTs and 1 observational study, suggested no significant detrimental effect of beta blockers on quality of life, but the evidence is of very low quality. Authors stress that future COPD trials must routinely include patient-reported outcomes and functional measures, as these are critical for clinical decision-making. Limitations to keep in mind. This review provides a balanced critique of the evidence. Key limitations include: 1. Most exacerbation and mortality data come from observational studies, which are prone to residual confounding. Sicker patients may not get beta blockers. 2. The FEV-RCTs had very small sample sizes, only 199 patients total across 12 trials. 3. Undiagnosed CVD is common in COPD, making it hard to isolate non-cardiac benefits. 4. Only 1 RCT, metoprolol, has evaluated exacerbations, and its results conflict with observational data. 5. Possible publication bias. And 6. No data on how beta blockers interact with rescue beta agonists during acute exacerbations. The authors intended to temper overconfidence and highlight the need for more research. Conclusions for clinical practice. This review distills the findings into 5 actionable takeaways for clinicians. First, the class effect of beta blockers in COPD is generally positive. Second, do not withhold beta blockers for cardiovascular indications solely due to fear of harming the lungs. Most are safe. Third, propranolol is the clear exception and should be avoided. Fourth, observational evidence suggests lower exacerbation and mortality risk. Fifth, the choice of which beta blocker to use should primarily follow cardiovascular disease guidelines, e.g., bisoprolol, metoprolol, or carvedilol for heart failure. The final message is memorable. Treat the heart, but avoid propranolol. The lungs will likely be fine.